All right, so it looks like the patient's having a tonic-clonic seizure. So guys, if I could just get the two of you to roll the patient on her side towards me. I'll provide some suction of the airway, the best that we can do, while the patient is still seizing. Maddie, I might get you to prepare for us some midazolam.
Sure.
We've got the IV access, so we'll use IV administration. If you can just prepare 2.5 milligrams of midaz for us,
Yep.
please, that would be great.
Confirming midazolam, expiry October 22.
Midazolam, expiry October 22, thank you. And Dan, are you comfortable to manage the patient in that lateral position on your own there? James, what I get you to do is if you can set up the stretcher outside for us and grab the carry canvas and put that in position so that we can prepare for extrication of this patient. So just stand by with midaz.
Sure.
I just want to make sure or give the seizure an opportunity to terminate on its own. And while we've got the patient on her side, I'll just have a quick look on the back to make sure that there's no abnormalities. I'll just run my fingers down the spine to see if there's any crepitus or signs of trauma, bruising or abnormality, and I'm not seeing anything back there. So I'll continue suctioning around the patient's mouth as best I can, given that we've got the trismus in place here. James, are you happy with the setup of the bed
Yep.
outside by the ambulance? That's great, thank you very much. And Dan, if we can terminate this seizure, or if this seizure terminates on its own, I'll get you to jump onto the airway for us with some ventilations, and I'll get you to pop in an OPA, providing you've got no trismus.
Okay, BBM with OPA.
BBM, thank you for the clarification. Alright, so still suctioning. You can see the patient's still got all over tonic-clonic activity here, and there doesn't seem to be any easing up of the seizure activity here. So, Maddie, I'll get you to stand by with the midazolam administration. I just want to give it 3 minutes to see if we have any termination of the seizure activity, and it doesn't look like we do. That's 3 minutes, so let's administer the midazolam, please.
Midazolam going in now. That's flush through.
All right, thank you very much. All right, so it looks like that seizure activity is easing up somewhat there, and looks like it's now stopped. All right, let's roll the patient back onto her back. Thank you. And so I'll get you to jump back onto BDM, please, with the OPA. I'll just have a quick look in the airway first, and I find that that is clear. No secretions, no sign of vomitus in the airway.
OPA in.
Thank you very much. So, by way of a breathing assessment, I see that the patient is breathing. The effort certainly looks increased. I'm feeling for a radial pulse, and I feel a strong radial pulse, and it is irregular. From a perfusion perspective, I noticed that the patient is pale and clammy. James, can I get you to get me a blood pressure, please? And then just perform a 12-lead ECG for us, that would be great. Thank you. Just looking at the monitor, I can see that the pulse is irregular, that it's around 98 beats per minute. So in terms of neuro status, Maddie, can you get us a BSL, please? We need to rule out hypoglycemia, and a temperature, please. I'm going to provide a painful stimulus to the patient and just check the GCS. So there's no eye opening from the trap squeeze here. there is a groan, so a verbal response of 2, and a motor response of seeing extension of both limbs for a score of 2, giving us a total GCS of 5. Just going to have a quick look in the in the pupils. Thanks, Dan. So I see the right is a size 3 and non-reactive, and the left I see is dilated and non-reactive to light as well. How do we go with the blood pressure there?
Yeah,
James?
so blood pressure is 180 on 100, pulse is 98, SATs at 89%.
Brilliant, thank you very much for that. Manny, how do we go with the BSL there?
So the sugar's at 8.8 and the temperature is 36.4.
Great, thank you very much. So just finishing off our respiratory status assessment, I can see that the rate looks increased. Do you mind if I get you to count a rest rate for us there, James? The rhythm looks even, the effort is increased, there's equal rise and fall of the chest, and I will now just have a listen. I can hear audible gurgling breath sounds there. Okay, so can hear breath sounds in the left and breath sounds in the right. However, there is a lot of crackles present in that right side, and so I'm going to put that down to aspiration, given the amount of vomit that we've found on and around the patient. How do we go with the rest rate there?
Yeah, rest rate of 25.
25, all right, thank you very much. So I think at this point it's looking very likely that there is some sort of neuro event happening with this patient, and stroke is pretty high on my list of differentials here for this patient, but I want to finish off the assessment and then we'll make a call on what to do next. Can I have a look at the 12-lead ECG, please?
So,
All right, so Dan, if you just want to have a look at this with me. So I see an irregular QRS, a narrow complex, and I'm not seeing any P waves here. So they're not discernible, and the rate is of the QRS is irregular. This looks like AF to me.
No, confirm AF.
Okay, that'll be our working diagnosis. Let's just do a head to toe so that we can rule out any traumatic causes of what's going on with the patient. So if I just have a quick feel of the head, I'm not feeling any contusions present there, and that all feels intact. I've got no blood on my hands. Just having a feel of the C-spine here for any crepitus or stepping, and I'm not feeling anything there either. So if I just have a feel of the anterior chest wall and the clavicles, that all seems intact. Laterally, seems intact, the chest wall, and it's not causing any additional pain to the patient for me to do that. Just having a feel through the abdomen here. So it's soft, non-tender, it's not causing the patient any additional pain, and neither is me pushing down on the pelvis. That all seems fairly stable. Going through and feeling the long bones of the right upper limb, do the same on the right lower limb. Cool. All right, left upper and left lower limb seem fine. I do note that there is some incontinence present as well. So I see no signs of any major external hemorrhage with the patient. If I ask the husband about any signs of forced entry, he replies with a no. I think we've got some pretty good history on this patient in terms of a headache. Around 7 o'clock this morning was when she was last known to be well, and then husband discovering her 5 hours later at 12 o'clock. in the state that we find her in at the moment. So thinking this patient, stroke is pretty high on my list of differentials for this patient. Would you agree?
I would agree, yes.
Yeah, cool. All right, we'll move down that pathway then. So I think this patient is going to require CT, it's going to require neurosurgery review, and the potential for endovascular clot retrieval as well. So I think we transport to that location, that is 35 minutes away from our current location. So I think in order to safely transfer that patient there, we'll perform an RSI and take control and protect this patient's airway. Does that seem reasonable to you?
Yes.
Yeah, yeah, cool. All right. So what I'd like to do is extricate the patient. So I think it would be unsafe to perform the RSI here in the bedroom and then have a tricky extrication with a intubated, paralysed patient. So we'll extricate, do it at the back of the ambulance, and we'll do role allocation there. Does that seem clear?
Good plan.
Good, cool. All right, so let's prepare the patient for extrication. Switch back to the non-rebreather mask. See, we've got the bits and pieces of the patient there, so that's great. And we'll get the husband to carry the oxygen and the monitor for us.
Non-rebreather back on.
Thank you. All right, everybody happy? All right, lift on 3, 1, 2, 3. Okay, that's great. So just lift up a couple of flicks. Thank you. All right, let's move the patient to position. That's great. All right, so we'll lift the head of the bed up a little bit. So we've got the patient at 30 degrees there. Dan, can I get you to swap back to BVM for us, please?
Confirm BVM.
Just going to have a quick look in the airway before we do that. And I see that the airway is clear. Thank you. Breathing is unchanged. Let's use the OPAs one. Sorry, Dan. Breathing is unchanged from how it was in terms of its effort. It's still present. And if I feel a pulse, it still feels strong, it's present, and irregular. Let's just go back over our perfusion status. So, James, if I can get you to get me an updated BSL. Our patient is now cyanotic as well as being clammy. So we've switched back to the BVM now. In terms of neuro status, if I give the patient a good hard trap squeeze, get no response from eyes, from verbal, or from motor. So we can say that the patient is now a GCS of 3. Maddie, can I get you to just check a second BSL for us, please, and just make sure that there's been no change there at all. From a respiratory perspective, I see that there's still equal rise and fall of the chest. The rhythm still looks equal and regular. James, can I get you to counter respiration rate for me, please? And I'll do the auscultation. Okay, left side sounds clear. Right side, I'm still hearing those crackles present there. How'd we go?
BSL's 9.2, Dan.
9.2, all right, thank you very much for that. I can see on the monitor that our blood pressure has now come back as 200/105, and our SATs are now at 88%. Hopefully that will change now that we've made the switch to the BVM. How'd we go there with the breath rate?
Breath rate 18.
18, okay, thank you very much. Cool, I think we are safe to go ahead with RSI.
Okay.
Yep. Okay, so just by way of role allocation, Dan, I'm going to get you to be the airway clinician.
All right, airway clinician, yeah.
I'll have you outline or assess the airway and just let me know if there's any anticipated difficulties there from an anatomical perspective. I'll get you to set out all the gear that you need for intubation and for a failed intubation drill, and I'll get Matt to take over the ventilation and oxygenation while you set all that up. I'm going to be your airway assistant once it comes time for the intubation, so I'll pass you all the gear that's required, and I'll also be the one to draw up the drugs that are required for intubation. So Matt, I'll get you to administer the drugs when the time comes for that. In just a moment, I'll get you to head round and take over oxygenation and ventilation of the patient while Dan sets up the gear. And James, I'll get you to obtain a second IV access, please, on this right side. And I'll get you also to hang a bag of saline. That's going to be a 1 litre bag for our pre-hydration, 10 mils per kilo, 90 kilo patient, 900 mils. I'm happy for that 1 litre to go through. Any questions or clarification needed?
All clear?
No, all clear.
Cool. All right. Thanks, guys. Let's go to it.
Yeah, thank you.
So the first drug I'm going to draw up here is fentanyl. We're going to use a 5 milligram per kilo dose of fentanyl. And so for a 90 kilo patient, that's going to be 450 micrograms of fentanyl drawn up as a push dose. Maddie, can I just confirm what drug this is?
That is fentanyl and expires in October 22.
Thank you very much. The next drug I'm going to draw up is ketamine. So ketamine is going to be 2 milligrams per kilo, so 180 milligrams for this patient, and again that'll be drawn up as a push dose. Maddie, can I just get you to confirm?
Confirming ketamine, expiry October 22.
Thank you very much.
Got a sharp out over here.
Thank
Sharp
you.
through out. Sharp through away.
Thank you. So I'm going to set the ketamine up as a push dose also. Next I'm going to draw up the rocuronium. Rocuronium is going to be 1.5 milligrams per kilo. So for a 90 kilo patient, it's going to be 135 milligrams. And I'm just going to round that up to 140 in 14 mils of rocuronium. So Maddie, can I just get you to confirm those for me?
I'm confirming rocuronium and expiry October 22.
Brilliant, thank you very much.
Sodium chloride, October 22.
Confirm sodium chloride, October 22.
And we're just going to go a little bit back again.
Litre bag, and we will let that run all the way through. Thank you. Okay, rocuronium will be also drawn up as a push dose. James, can I get you to confirm the metaraminol and the expiry date for me, please?
Certainly, that is metaraminol, and expiry is October 22.
Thank you very much. We'll use this in the event of a hypotensive episode with a systolic pressure less than 120. Concentration is 1 milligram per mil, and we will use a dose of 0.5 to 1 milligrams in 0.5 to 1 mil in the event of a hypotensive episode.
IBCs in and running down.
Perfect. Thank you very much for that, mate. Very much appreciated. So the last drug I'm going to draw up is atropine. So just a single dose of atropine is going to be 0.6 milligrams in 0.5 mils in the event of a bradycardia less than 60 beats per minute. Can I just confirm with you the drug here?
Yep, that is atropine, and expiry date is October 22.
Brilliant, thank you very much.
Thank you.
All right, Dan, are we expecting any difficulties with from our airway assessment there?
No, we've got a good Mel score. But no difficulties expected.
Perfect. Thank you very much. I think we are. Are you just marking the?
Yeah.
Yep. Excellent. Thank you. Everybody happy with where they're at?
Yes.
Okay. So Dan, I'll get you to take over ventilating the patient, and we'll start our pre-oxygenation. So I'll just attach our PEEP valve, and we'll dial that up to 5 centimetres of water. You happy to focus there on the pre-oxygenation?
Yes.
Perfect. All right. So just a reminder, Dan, airway clinician.
Airway.
I'll be the airway assistant. Maddie, you'll administer the drugs, and James, if I can get you to read the checklist, please.
Certainly. O2 supply.
We have 2, one for the BVM and one for the nasal prongs, both set at 15 litres per minute.
Patient position.
We have 360-degree access to the patient. They're in the head-up position and the sniffing the breeze position.
Airway assessment.
Our airway assessment came back as not expecting any difficulties from an anatomical perspective.
Pre-oxygenation.
We're pre-oxygenating now, and we have our PEEP valve in place, set at 5 centimetres of water.
Monitoring.
We have the ability to monitor end-tidal CO2, the heart rate and rhythm, pulse, O2, SATs, and yes, that's it.
Hemodynamics.
We have our 1 litre bag of saline running open for our 10 ml per kilo prehydration dose. If that hasn't finished at the time of induction, I'm happy to go ahead given our hypertensive state of our patient.
Analgesia.
So we're going to use a dose of 5 micrograms per kilo of fentanyl, which is going to be 450 micrograms. That's drawn up as a push dose.
Sedation.
We'll use 2 milligrams per kilo of ketamine, and for a dose of 180 milligrams, and that has been drawn up as a push dose.
Paralysis.
We'll use rocuranium, 1.5 milligrams per kilo, which is being rounded up to 140 milligrams, also drawn up as a push dose.
Other.
We have 2, atropine, which is a single dose of 0.6 milligrams in 0.5 mils in the event of bradycardia, less than 60 beats a minute.
BVM.
BVM is in use and working. Sorry, I forgot to mention the other drug that we were going to use is metaraminol. That is drawn up as it's a pre-filled syringe at a concentration of 1 milligram per mil. In the event of an episode of hypotension, less than 120 systolic, we'll administer 0.5 to 1 milligrams as required.
CMAC or laryngoscope.
So both are available as per the airway plan.
SGD or ETT.
Okay, we have an iGel appropriately sized, lubed up, ready to be deployed if required, and 2 endotracheal tubes present. One of the size that we intend to use, which is a size 7, and one size smaller, with both of those cuffs having been checked.
Yes.
And their integrity intact.
Secure.
We have cloth tape in position, ready to go.
Suction.
Suction is behind the patient's head, ready to deploy if needed.
Bougie.
With the airway gear and ready for me to hand to the airway clinician.
Surgical.
We have all the gear required for front of neck access, and the cricothyroid membrane has been pre-identified and marked.
Fertilizer airway plan A, B and C.
Plan A will be direct laryngoscopy with a MAC4 blade and bougie railroaded over the tube. If I can't get a grade 1 or 2 view, we'll return to oxygenation by BVM and then prepare for a video laryngoscopy. With a hyperangulated blade, utilising this technique, will be performed with a straight cuff to the stylet tube. Should this fail, we'll move to Plan B. Plan B is going to be an iGel supraglottic airway device. If this fails, we'll move on to Plan C. Plan C, in the end, where we can't intubate, can't oxygenate situation, Dan, you'll perform the surgical airway, and my role will be to extend the head and neck to bring the larynx as superior as possible, and Dan, you will then clean and perform the procedure. As mentioned, the cricothyroid membrane has been pre-identified and marked.
Great, thank you very much.
Perfect. Checks complete. Commencing RSI at 21:09.
Perfect. All right, thank you very much. I see our SATs are at 100%. We've still got radial pulse present, irregular as it was, and respirations still ongoing as they were. I think we're safe to proceed. Maddie, if you would administer the fentanyl, please.
Fentanyl, Dan.
Fentanyl confirmed, thank you. And James, if you can mark that down
That is
please.
2110 for the fentanyl.
Perfect, thank you. Let's go ahead straight into the ketamine administration.
Ketamine confirmed.
Thank you. And James, if you can note that time of administration down, please.
Once again, 2110.
Start the timer and allow that 30 seconds to work. And Matt, if you can stand by with the rock uranium.
Sure.
I just want to make sure that even though our patient is GCS3, that there is no awareness of any paralysis after the administration of our rock uranium.
And that is 30 seconds now.
Thank you very much. Let's go ahead with the rock uranium.
Rock uranium's through.
Thank you. If we can start the timer for 60 seconds there, James.
Start the timer.
Give us a warning at the 45-second mark, and if you can note down that time of administration as well. Thank you. So we want to allow 60 seconds for the rock uranium to take effect, and we should see the cessation of spontaneous respirations as well as the loss of muscle tone, noted most prominently by the airway clinician, with the jaw becoming relaxed.
It's 45 seconds.
Perfect. All right. How's that jaw feeling there?
It does feel relaxed, yes.
Relaxed. All right, that's good.
60 seconds.
Perfect. All right. Let's go ahead.
Thank you. The lips, teeth, tongue, uvula, to the space. I can see the epiglottis. I can see the adenoids. I have a grade 2 view.
Perfect.
I'm down and through the cords.
Excellent.
May I have the tube? I have the tube.
Got the bougie.
Advancing the tube. Alright, I'm down, black line through the cords,
Thank you.
and I appear to be about 22 at the teeth.
Perfect. Comforts up. And bougie out. So let's connect up the circuit and we'll be able to test that out. We've got a hold of the tube.
I have the tube, I have the bag.
Perfect, thank you. I'll auscultate. Okay, epigastrum. Right, no sounds in there. Okay, breath sounds in the left. Breath sounds in the right. That's great. I'm seeing equal rise and fall. I'm seeing misting in the tube. And most importantly, I see that our end-tidal CO2 waveform has come back as a tracheal looking waveform. I'm happy that this tube is in the trachea. You're
Yes.
happy?
Confirmed, I'm happy.
Cool, excellent. All right, so we'll just secure this in place. And pop the bite block in. What I get you to do, Dan, is if you can squeeze the bag once every 4 seconds, and that'll give us a respirate of 15, just with
Okay.
one third of the bag until we can switch over to the ventilator.
Copy that.
James, I'll get you just to get us a post-procedural set of vital signs for me, please. Maddie, can I have you draw up some morph Medaz into a 20ml syringe?
Sure.
That'll be 15 milligrams of each, and we'll use that as our maintenance sedation. So I'm thinking of using a dose of 0.1 milligrams per kilo per hour. So for a 90 kilo patient, that's going to be 9 milligrams per hour for our maintenance sedation.
Confirming morphine midazolam expire October 22.
We have morphine and midazolam both expiring and in October 22, thank you. I'm going to maintain paralysis with rocuronium, and we'll administer that in approximately 20 to 25 minutes time. So that'll be once we're en route to hospital. Have we go with the vital signs there?
Yeah, so pulse of 110, blood pressure of 160 over 100,
Yes.
SATs of 100%, and ETCO2 is 45.
That's great, thank you very much. So Dan, once we're in the back, we'll switch over to the ventilator. We're going to use a lung protective strategy. So we'll use a volume control mode. We'll use a tidal volume of 6 mils per kilo. So for a 90 kilo patient, 540 mils. We will set the rate at 15, an IE ratio of 1 to 3, PEEP at 5 centimetres, and a FiO2 of 1, and we'll titrate that down to 0.5 once we're en route to hospital. Happy with the morphmidaz?
Morphmidaz is prepared.
Great, excellent, thank you very much. And Maddie, in just a moment I'll get you to jump in the driver's seat and I'll have you drive us to hospital, if that's okay. Once we're in the back on the ventilator, Dan will get you to place a nasogastric tube in, and we can decompress the stomach, and we can take the eyes and do the eye care once we're in the back there. I'm also going to make sure that we target our ventilation strategy to make sure that we maintain a normal CO2, so somewhere between 35 and 45 millimetres of mercury. We're also going to tailor the sedation to ensure that the patient remains adequately sedated. If we see a trend of tachycardia and hypertension, rising blood pressure, as well as signs and symptoms like tearing up in the eyes, then we can assume that the sedation is too light on, and we can either up the sedation or just give a 1 to 2 milligram bolus to make sure that sedation is adequate for our patient. Is everybody happy with everything they see here? Any
Yes,
concerns?
okay.
No? All right. What I get you guys to do then is we'll load the patient in the back. Dan, if you can oversee that since you've got the control of the tube there, and I'm just going to make a quick phone call to the hospital and just give a handover. So this is Daniel, paramedic from Western Australia. I've got with me a 38-year-old female here with a working diagnosis of stroke. She presented this morning at 7 o'clock with a headache, which was the last known time she was seen well. Her husband discovered her 5 hours later at 12 o'clock, and that was when he discovered her in the condition that we found her, which was a GCS of 5 and an airway and surroundings full of vomit. So her current vital signs are her heart rate is showing AF. It's matching the pulse, which is at 110 beats per minute. We've got a blood pressure of 160 over 100. Our SATs are 100%. Our end tidal CO2 is 45 millimetres of mercury, and our rest rate is at 15. She is currently intubated. We have provided that by RSI. She's being maintained on a morphmidaz infusion, as well as maintaining paralysis with rocuronium. She's got no allergies, no medications, and no past medical history. Her husband is aware of what's going on with her and where we're taking her. Our ETA is 35 minutes from our current location. Do you have any questions for me?